is most of the postgraduate residents are sitting. So mostly they work in the accident emergency department. They have their duties, most of the medical officers. And it is very important to know when a patient comes with unconscious state or with low GCS. So I would like to invite our fourth speaker, uh, Dr. Abdul Naeem. He is consultant intensivist actually. The topic would be approaching the unconscious patient, essential strategies in acute medicine. So please come forward.
Bismillahirrahmanirrahim. I am thankful to Pakistan Society of Physicians, especially Dr. Awais Naeem and Professor Usman and Dr. Fahad for inviting me for this session. The topic is important, and this is basically how you approach a patient who is unconscious. He can present to you in emergency, he can be already in the ward, and then he become unconscious. So my task was to develop a strategy that how we can examine and manage this patient. So the objective was this. So how we can do that? We can do by identifying the cause, and we can work up for initial management. Of course, history is also important in these cases. I think we should go, because of lack of time, we proceed to the topic. First, we will define what is unconsciousness. It's a state when the patient is unresponsive to external stimuli, including pain, and cannot be aroused. It is very common in emergency department. You see lots of patients coming with the unconscious state. How you assess? It was a difficult sometime, and it's sometime we confuse that what to do next. I'm trying to make it a simple approach so it would be easy for postgraduate trainees and working in emergency and ICUs. You have to go by system wise, but system doesn't mean that you have to start from head to toe. You have to develop according to the best possible response so we can treat the patient. First contact is, you have seen a patient who is unconscious. Suppose you are working in emergency department and there is some unconscious patient. What the first step you have to do? Even you can, you can make it interactive, you can give your answers. Always assess the patient is coming with shock or without shock, because this will make your priorities to treat the patient. If patient is coming with shock or without shock. If patient is coming with shock, then we have two jobs to do. So you have seen the patient, shock, stable. Second is, if shock, then we have to make two tasks: stabilize, forget the cause, whatever is the cause of unconsciousness. First stabilize the patient who is in shock, and then identify type of shock. We can go one by one. Of course, the gold standard is ABCD: airway, breathing, circulation, disability, exposure, and connect the monitors. This is routine you are doing. Just I am trying to make it in a rational way. With a monitor, you can check the oxygen, heart rate, you can do the ECG, blood pressure, and temperature, and you check the blood glucose. These are the simple bedtime tests, and these are normal reflexes of any clinicians. So for the stabilization, airway, you see the patient is, of course you have done the vitals, and now you are checking for the airway. If the airway is patent or no, there is some obstruction, tongue is falling back, something is inside the airway, then you have to, maybe patient is GCS is very low, he is not responding, he is drowsy. If you consider that his body tone is also gone down, then you have to protect the airway, because it will cause collapse of the airway. So you can, first reflex is very simple: turn the patient to one side, either right lateral or left lateral. This is like we are shifting the patient of cardiopulmonary arrest patient to one side. It's one of the recovery position. It will prevent two things. One, it will prevent hypoxia, because airway would be patent. Second, it will prevent aspiration. And of course, next is you can insert the airway, you can use endotracheal tube, and you can connect to ventilator. Then we have different options. But airway, because before start putting any intervention, if you see patient is not responding, turn to one side until you put the airway and fix it. Then you give the oxygen. It can be with low dose oxygen, 0.5 to up to 15 liter we can give. And at the same time, if patient can, we can use nasal cannula and high flow oxygen, BiPAP, and even ventilator. We can adjust according to we have connected already the monitors. We can adjust the oxygen. Coming to the circulation, A, B, C, D. Check the blood pressure because we have seen that. We have seen the heart rate. And these two are important. Either in the blood pressure there would be hypertension or there would be hypotension. We can manage the hypotension because he is in shock. What we can give IV fluid, we can give vasopressors and different types of vasopressors we can give. If patient is having bradycardia, tachycardia, we can manage. Of course, tachycardia sometimes can cause confusion in different conditions. If bradycardia, you can use atropine or dopamine as well. Then you assess for disability because these are the basic steps for saving a life. Now the disability, you assess the conscious level. There are different scores are being used, Glasgow scale. Whatever you are competent, you can use that one. 4 score, there's another one, this AVPU score, this one you can use. Whatever is comfortable for you, you can use. And there are different other clinical criteria, already news score and this score. Wherever you are comfortable, use this one. Don't go in any score where you are not expert. And you can assess for disability. Maybe there's some lung injury, or maybe limbs are damaged. Maybe patient is bleeding. You can have a secondary survey look. Expose the patient to find if there's any cause. That can give you a clue. Maybe you are not considering this is surgical. It can be surgical. Maybe patient has fallen down and developed subdural hematoma and now he is drowsy. So you have to expose, or maybe he's wearing the cap. So look for any signs that is comfortable for you to assess the patient. These neurological assessment, Glasgow scale and other scores, you can do that, whatever you are comfortable. Next is, of course, one of my colleagues has made the job easy. That you can check for the pupil response and corneal reflexes and decorticate and decerebrate posture. I will not go in details. It has been discussed already. Now you have stabilized the patient. Patient unconscious, shock, without shock, shock patient, stabilize the patient, ABCD approach, and now patient is stable. So after stabilization, what next is? Again, the 2 tasks. The one we have done already. The second one is cardiogenic shock. Cardiogenic, septic, neurogenic, and hypovolemic. I changed this terminology because of, you can say, obstructive shock and distributive shock. Sometimes it is difficult to assess in emergency conditions, so we can manage this one according to the cause. Cardiogenic shock, patient may have near arrest, he is coming to you, now you have stabilized, but patient is still drowsy. These can be different causes, myocardial infarction, arrhythmias, and cardiac tamponade. My colleague has already discussed making the job easy. And we can get the clues, we can take the history from the family or someone who is bringing them, or maybe some trace evidences are there. We can, for cardiac, of course, ECG, this can be done in emergency. Cardiac enzyme, troponin I, it's an urgent test, we can do that. Echo, it's a bedside now. At the same time, we have point of care ultrasound. It is now recommended that emergency physician must know the point of care ultrasound they can do on the bedside. Similarly for septic, remember this is cardiogenic can be within second, but septic will not cause acute emergency like same day. If infection is coming, someone is getting the infection, it will take 24 to 48 hours to get the septicemia and then septic shock. So most of the time these patients have history until there's no one attended with them. Then you can go for the organ specific workup. Chest, most common, the chest is common, the chest infection, aspiration, pneumonia, these are there, urinary tract infection. This is the infection which is commonly missed in our settings because we don't pay attention to the urine. And urine is like, especially for old age, even they cannot express this finding and they come to you in the shock state and you're doing all the other investigation and you're not doing urine RE. And when you do urine RE, you will see numerous pus cells causing the sepsis. Then of course cellulitis and toxic epidermal necrolysis. Elderly patient, they have non-specific symptoms. So we must understand that we must depend on the investigations and radiology. It is easy to understand for the body infections that cavity infection and solid tissue infections. Solid tissue infection will cause pain. Suppose I am having some infection here. This is skin. Skin will cause pain. But in the cavity, we have 5 cavities in the body. One is cranial cavity, pericardia, chest, and abdomen, and the bladder cavity. These cavity infections, they are painless, and patient will not notice, especially in old age or when the reflexes are low, immunocompromised state. Infection will go very rapidly, and it will develop automatically septicemia, septic shock. When the patient will come with septic shock, then you will identify. As in old age, especially for males, that there is prostate, it causes retention of urine, and sepsis is more common. Hypovolemic, of course, most of you know that we can assess the patient who is in hypovolemia and there's evidence of bleeding. This can be internal bleed or can be external bleed. Then you have to go for organ-specific workup. For spinal, of course, patient may have some spinal acute shock. Patient is having history of metastatic stage 4 disease and now coming with sudden weakness and then again collapsed. Maybe patient has some surgery before or there's any premorbid conditions. Remember one more thing, toxin and poisons. Poisoning can be, you can say, accidental or incidental, and sometimes someone has given the toxin. It can be like patient has taken, instead of paracetamol, he has taken some other drug. Recently one case came to me, husband and wife. Husband was having, just imagine, was having stroke and he's bedbound. And wife was having dementia. And the wife is giving the medicine to the husband. Disaster. So it was not intentional, but mistakes can happen. So I asked the family, please, any sensible person should give the medication. And what happened? Wife took his medicine and given to the husband, and his medicine, she took it. Both came to us. So we have to trace the evidence and remember that it has a medical aspects. If you're suspecting, you don't know this is by incident or someone has taken the intention, and it is common, especially in underdeveloped countries where the access is easy. You can get any tablet from the medical store or you can make some extra syrup at home. So this is common. Always take blood and urine toxicology to save your skin, because you don't know the patient is coming to you. What is the intention for him? He may say that इसको accident हुआ था तो उसके बाद हमने इसको ये दवाई दी थी. Maybe he has taken medicine. So now coming to patient who is not in shock. So our task is the same, systemic examination as we had done in the previous case. All the system we will check one by one. Now patient is stabilized. So you are more relaxed. Now you find the cause, you go by system. If the patient is now stabilized or coming to you in a stable condition without shock, what are the common CNS infections that can cause a patient to be drowsy? Maybe he's already in the ward and now worsening condition, a new onset of the disease can be there. It can be meningitis, encephalitis, and brain abscess. Unfortunately, one patient came a couple of weeks back. He was having some otitis interna, and now the patient developed brain abscess, and he came to us fits and collapse. CNS tumors can be there, stroke, infarction, hemorrhage, pituitary apoplexy. This is a rare emergency. Patient has pituitary fossa tumors, and suddenly the blood supply is compromised and they come unconscious. Status epilepticus, even the cardiac syncope and arrhythmias we have already discussed. And the respiratory, CO2 narcosis. Patient who are smoker are having end-stage lung disease. Most of our patients, because we don't have lung transplant, so it is common for them. Sometimes they need more oxygen, sometimes they need less oxygen, and they are using the same settings of BiPAP at home, so it is common for them. Acute life-threatening asthma, because they are taking inhalers at home. Some patient cannot afford to go to hospital, or they have some restrictions. Tension pneumothorax, aspiration, we have discussed. Uremic encephalopathy is another cause. So you have, after stabilization, send all the base scan investigation. We will discuss in a minute. and electrolyte disturbances, especially hyponatremia and old age. One common finding I have seen that patient is hypertensive and taking hydrochlorothiazide. Sodium becomes gradually slow. Initially, patient is compensated and patient is awake. And then what happens? When it goes less than 120 or less than 110, patient becomes drowsy. It's one fine finding, you find patient is collapsed. Not collapsed, but patient is comatose. When you work up, I have seen sodium of 92, 93, it was common. GIT, of course, peritonitis and pancreatic diseases they can cause, and some colon diseases as well. Hepatobiliary cholangitis causing the sepsis, hepatic and calf, vernix and calf, where the people are using more alcohol. I work abroad a lot of time, and vernix is much common. Other is mixed edema coma. Endocrinologists have more experience in that one. Hypoglycemia and hyperglycemia. As one of colleagues mentioned that hyperosmotic non-ketotic coma as well. It is one of the cause of unconsciousness. And hypoglycemia, of course, everybody knows. So we have to do the blood sugar immediately on the bedside. We have to check the electrolytes, kidney and liver functions. Of course, the ABG is the most important, which will give you patient is acidotic, hypoxic, or carbon dioxide retention. Then we can go for imaging, CT, MRI, especially for the trauma cases, we can proceed for trauma CT, toxicology screen, infectious disease workup, procalcitonin, CRP, blood cultures, urine culture, any wound cultures, and the cardiac monitoring, of course, ECG. When the patient is stable but unconscious, shift the patient to ICU. Even for hemodynamic monitoring, patient needs to be in ICU. There are now many indications to shifting the patient to ICU. But the problems are in ICU, no bed available most of time. Second, if in private setup, I work also in government and private. In the private, the charges are much high. Airway management, ensure the airway protection, intubate the patient if GCS is low, usually less than 8, we intubate the patient. Oxygen we have given. If patient has taken some toxins like poisoning with drugs, naloxone, we can give for opiates, we can give flumazenil for benzodiazepines, for organophosphorus, we can give pyridoxine, seizure control and sportive management. There are some special conditions, I don't remember my colleague name, but he has mentioned already. The common problems we face, especially in the internal medicine, what is delirium, vegetative state and locked-in syndrome, and brain death, excellently covered by Dr. Ibrahim and Dr. Imran. Delirium is an acute fluctuating conscious level with altered mental state. It can be due to infections, it can be due to metabolic derangements, or any medication has taken. Why the coma is deep unresponsiveness to without meaningful interaction with the environment. So coma is different and delirium is different. In delirium, patient can be drowsy, but in coma, no response. The cause of coma is severe neurological injury or metabolic disturbance. Vegetative state or persistent vegetative state. These are important for internists to understand. Condition of wakefulness without awareness. Patient is awake. You feel patient sometimes making some movements. He can open eyes and he can exhibit spontaneous movements and with normal sleep pattern. He may be awake in the morning and in the night he can go to sleep, but patient is not conscious, which we face in ICU most of time and causes severe traumatic injury, hypoxic or diffuse brain injury. These are the causes. No meaningful purpose response to the environment. He will not consider whatever you are doing. But reflexive moments are there. So manage the underlying cause and treat accordingly and inform the family. Locked-in syndrome, this is, I feel, the most miserable condition in these comatose patients, we can say. It is a rare neurological condition. Patient is conscious but aware. You see the patient cannot move, patient cannot respond, but accept few responses, but he is awake, he can understand, but he cannot communicate to you. So paralysis of most voluntary muscles. He cannot lift the hands or legs or chewing movements, just only what can do because the problem is in the brainstem, especially in the pons. And what happens, patient can move only their eyes, up and down and sometimes lowering of eyeballs. He understand he is hungry, he need food, but he cannot communicate to you because voluntary muscles, they are not working. So no verbal response, patient cannot talk, but patient is suffering pain, he cannot tell you that I have pain. Management, early diagnosis and support the communication. Sometimes we use the communication assist devices. Psychological support for the patient as well as to the family. You have to communicate to the patient in this condition. Inform him because he is understanding. Sometimes we can make a rapport with that one. Brain death already well covered. It's a legal point, especially from insurance point of view. Diagnosis of irreversible or cessation of brain activities, especially the brain stem, because brain is vital for heart and lungs and other main areas. Causes we have discussed. No cranial reflexes, no pupillary right reflex or cornea, no respiratory support, no response to stimuli, whatever stimuli you are giving. Confirmatory test, most of the time EEG we are doing, and then CT angio. I did one patient, I think 3 months back, CT angio, to confirm the brain death. He was a young boy of 36 years and was having on end-stage renal disease, and he missed the dialysis session, and he came us with hyperkalemia and all this one. Then it was managed, the shock, and now patient is vitally stable on ventilator. But then we did the CT angio, there was no blood. So brain death is irreversible. Legally, patient has died. Focus on the organ donation if possible. There are some special consideration that trauma. Focus on C-spine precaution, as we have discussed, one of my colleagues. Pregnancy in the preeclampsia, eclampsia and hemorrhage, these can present to you with unconscious state, drowsy. And pediatric patients, you need a different approach to assess them because most information they cannot tell you. Elderly patient we discuss. Now the take-home message is, recognize the shock early and treat for stabilization. Second one is structured approach for stable patient, that A, B, C, D, E until they are improved. Identify and tailor the management to underlying cause. These are important because nowadays the medical field is not easy. We are always on toes. Remember that, don't be panic. Stay calm, even in ICU. Then you can make a good decision in ER, in the ward where the critical condition is, and calm the family. If you are not panic, so you can calm. If you are panic, so it is difficult. So if you understand the knowledge, how we can stay calm, because A, B, C, D, you see the patient with the shock state or without shock, the condition, systemic approach, you can manage the patient well. Thank you.